colleagues. Good morning, good afternoon, good evening. My name is Gedik. I'm coordinator of health workforce in WHO Eastern Mediterranean Regional Office. It is my great honor and pleasure to welcome you all to the fourth of the Asia Pacific Action Alliance on Human Resources for Health webinar series, which is on occupational health and safety of health workers during COVID-19 pandemic with a focus on healthcare worker infections. Let me start providing an update to participants who just joined this session. AAAH, the Asia Pacific Action Alliance on Human Resources for Health, which is known as AAAH in short, is a regional partnership mechanism launched in 2005, recognizing that internationally there is a need for global and regional action to strengthen country capacity for human resources for health planning and management. Biannual conferences are the main platform for AAAH for learning and sharing knowledge related to health workforce and strengthening health workforce capacities. Due to COVID-19 pandemic, the planned AAAH conference this year has been transformed to be an online conference on healthcare workers in response to COVID-19, which will be held on 18 to 20 November. Preceding to the conference, a series of webinars are being held in collaboration of AAAH Secretariat, WHO regional offices of Eastern Mediterranean, Southeast Asia, and Western Pacific regions, ADB, JICA, and USAID. The first group of 3 episodes focused on mobilizing surge capacities and addressing health workforce shortages. Now we are starting the second set of webinars, and our focus now is healthcare, health workers, health and safety and risk protection. As we all know, healthcare workers have been at the forefront of the response to this unprecedented COVID-19 pandemic that resulted with increased workload and risks for health workers. The increased workload has not only led to shortages, but also to a highly stressful working environment with long working hours, psychosocial distress, fatigue, occupational burnout, and sometimes even physical and social violence. Health workers are also at risk of becoming infected and even losing their lives. And they may even fear transmitting the infection to their families and beloved ones. So the webinar, which we're going to have next week, will address the psychosocial and mental health aspects, impacts of COVID-19 on health workers. And today, we are focusing on healthcare worker infections and how can we protect them. Unmitigated and rising infection and mortality rates among health workers does not only paralyze countries' response to COVID-19, but also have significant and long-term impact in the healthcare delivery, particularly in health systems that are already facing workforce shortages even prior to the pandemic, due to lack of trained health personnel and international mobility or geographical maldistribution or other challenges. And this has been worsened during COVID-19 pandemic and also with rising infections. We unfortunately do not have a comprehensive information on the magnitude of healthcare worker infections regionally or globally. We have some information received from some countries and also some emerging studies and publications on that. And we have different numbers which provide some indication. For example, a study which reflected the situation up to mid-May presented that the proportion of healthcare worker infections are about 4% of the total cases. Another ICN study found with data from 30 countries, the healthcare worker infections for nurses is about 6 to 7%. In some countries where there is a better recording of healthcare worker infections, mainly in European countries, we can find this figure around 10, 11%. For example, in the region that I'm based, in the Eastern Mediterranean region, we have this figure varying from 1% to 15, even 20% among different countries. So with, again, some average between somewhere between 6 to 10%. We are all aware that these figures are very much underreported in many cases. For example, a recently published prevalence study in the US showed that there were positive antibody was among the 6% of the health workers, and while 30% of them were asymptomatic. So that gives us a bit of indication that the numbers are much higher, and especially if we think that the total number of cases are about to reach to 30 million, and if we consider 5 to 10% of these cases are health workers, this is a significant number. So all these varying numbers, even though we don't have the figure, all these indicate the problem and the importance of reducing risk to ensure the safety of health workers, and which is also well recognized and adopted as the theme of the coming World Patient Safety Day on the 17th of September. So, magnitude, yes, we will look at the magnitude during today, but beyond the magnitude, this session will explore what are the surveillance monitoring mechanisms for the infections among health workers. What are the measures different countries are taking to reduce the risk of infection, including provision of personal protective equipment, training, different work arrangements, quarantine, etc. What are the treatment and compensation mechanisms for infected healthcare workers and other issues related to that, which will help us to learn for this period, improve our actions, and also get better prepared for the future. Without further ado, I would like to hand over to my colleague, Dr. Thomas Zapata, who is Regional Advisor on Human Resources for Health in the WHO Regional Office for Southeast Asia. Dr. Thomas Zapata will facilitate and moderate the session, and we are looking forward to hearing different experiences from the presenters, our commentator, and all the participants. So thank you very much, and it is over to you, Thomas.
Thank you very much, Gulen, for the good introduction. Good morning, good afternoon, and good evening to everyone. In the previous webinars, we had around 200 participants per webinar from around the world. So that's why I think we have to greet in different ways. So it's my great pleasure to be here and moderating this webinar, which is the fourth, as Gulen already mentioned, on occupational risk protection of health workers. Let me explain very briefly the structure that we are going to follow. First, we will have three speakers, three panelists, presenting their country experience from Egypt, Thailand, and the Philippines. Then after that, we'll have a commentator which will reflect on the presentations made by the three speakers. And then we will move to a Q&A, a questions and answers session, which will be long enough so that you will have an opportunity to ask questions, to share experiences, or to raise concerns on comments. And you can start doing that right now. So while you are listening to the first presenter, you can already start asking questions by going to the Q&A box that you find at the bottom of the screen. You will see a small box there, Q&A. If you click there, you will be able to type your questions. So we really encourage you to start asking questions since now. I mean, as soon as the first presenter starts speaking, and then we will go through them, okay? So let me introduce now the three speakers we have. The first one is Dr. Ihab Atia. He's the General Director of Infection Prevention Control in the Ministry of Health in Egypt. Second, we will have Dr. Somkiat, who is the Senior Advisor on Occupational Environmental Health in the Ministry of Health in Thailand, and he was the former Director of Occupational and Environmental Health in the same ministry. And third, we have Dr. Kenneth Ronquillo, who is the Assistant Secretary for Health Policy and Systems Development in the Ministry of Health in the Philippines. So now we are going to start with the first presenter, who is Dr. Ihab Atia. Over to you, Dr. Ihab.
Thank you very much. Thank you for letting me have this opportunity to speak about Egypt experience in COVID during COVID-19, which I think it was hard time for everyone. Egypt is a 1 million square kilometer country. It is have 100 or around 100 million population. It is distributed on 27 governorates, and Cairo is our capital city, with about 20 million population. Infection control program is well established since 2003. It has the hierarchy is my department in the Ministry of Health. It is a general directorate. I have about 12 doctors and about 6 administrators with 27 branches in the 27 governorates. These are the infection control departments in the governorates, and each hospital have its own team. It's at least 1 doctor and 2 nurses, and 1 nurse for each 100 bed over. And this is our logo, ICP Egypt. This is the first guideline established, were published in 2003. We are now going to publish the 5th edition with 2020, inshallah. First, I have this opportunity to discuss about who are healthcare workers. What is the definition of healthcare workers? Are they, because the definition and WHO have a wide range, and we have to discuss about it. If we are speaking about occupational exposure to patients who are in our responsibility to prevent a spread of infection, sometimes administrators and security and others do not at any way deal with these patients. So if we are talking about occupational exposure, we are dedicating doctors, nurses, sometimes generators, but not all the hospital. This is matched with hospital acquired infection, but there is a big difference between hospital acquired infection now and pandemic, because pandemic is coming from community inside the hospitals, not from hospitals to workers inside or visitors. Sometimes it is healthcare workers are defined according also to personal ID, which means that an old doctor who is not working now in hospitals from about 9 years is considered also a healthcare worker in his morbidity or la qaddar Allah, his mortality. So we have to discuss about the definition of healthcare workers for records. Healthcare workers infection, I heard about in the introduction about the ratio between healthcare workers infection among the community or among the whole confirmed cases. But we cannot depend on this, because Some countries are making a very huge PCR examination to the public, and others restrict this PCR tests to the public. Sometimes they enter the hospitals and come and take their treatment without PCR. So sometimes the only population that can do PCR regularly are healthcare workers. That make the ratio irrational, because it increased so much in healthcare workers, but there is no PCR confirmation for the population. The risk factors that I need to discuss about it here, that healthcare workers are more likely to infect it, as all you know, because they are a part of the community. So when the pandemic spread or the infection spread among community, sometimes it affects our healthcare workers, and we cannot prevent that in homes. We tried, but it is very hard. Healthcare workers are the only people who work during that days we prevent other workers to go to work, and also they deal with infected people regularly. We need to analyze why they are infected, and this is what I'm going to discuss about with you the last 3 slides. Source of recommendation is a very challenging during the pandemic. Social media and everyone are speaking in infection control. Everyone can do their recommendation, and the government side or the science side cannot always be the upper hand in this source of recommendation. Sometimes we must to deal with irrational, illogic thinking just because social media is encouraging them. The analysis that I'm going to discuss about it with you, we have do a risk assessment for all healthcare workers who are infected, whatever they are, security, doctors, nurses, administrators, whatever. But the coming analysis will be restricted on doctors, nurses, and workers inside the hospitals. Next slide, please. This is the first draft. We found that females are about 54% of the whole infections, and males about 46%. Nurses about 59%, physicians about 24%, technicians, whatever they are working in, are 5%. Ambulance and ambulance drivers are 2%. Pharmacists are 1%. Others, if we cannot find their job exactly, they are 8% from the whole infection by exposure. And this is what we have understood from the analysis. Occupation are only occupational exposure, or that I mean working with confirmed cases, are only 23% of whole infection. 37% are inside the hospital, but from peers, from colleagues, by social exposure to each other. One of colleagues are infected who infect others. And this is make us response by changing some training for them. 14% are community exposure coming from their husband, their wives, their family, are 40% infected from healthcare workers. 25% we couldn't, they are not cooperative, or we couldn't find them to make the analysis with them, make the risk assessment with them. But we have to consider this: 37% from peers and colleagues, social exposure inside the hospital, 23% occupational exposure to patients, 14% from their families and their community. What we have done to respond to this, we have changed. We do a regular supervision and monitoring visit, which we visit all Egyptian hospitals annually, once per year, and we are then we take some measures to decrease or to face their problems inside the hospitals. So we have done some changes in this regular visit by the checklist. We insist the visitor must go to the hostel physicians hostel and nurses hostel and workers hostel, and also to the restaurant. We have prevented any way of eating together at any side of the hospital. The place also is dangerous place to infection is the director office, where they meet together every day, or they have taken rest with the director before leaving. This place, they are not adherent to their PPEs or the infection control measures, because they think they are dealing with their colleagues. And this is the very dangerous area to be infected are these places, the hospital, the restaurant, and the places where they take rest and meet with each other, like director office or the physician's place to meet. We have done about 3 videos on the social media. I can supply the link to you, give the link to you, by what measures to take inside hospitals by healthcare workers. And about 3 million people have seen these videos. We have done an online training for IPC hospital, and stress on these areas also to take care of infection at these places. I am doing a weekly Zoom meeting with the director of the 27 governorates to discuss about what's new about the analysis, where are the places that they emerge more infection than others, and we have received all the questions they need to be answered every week. We have been a very important, we have taken a very important role in approval of PPEs to be distributed to doctors during the pandemic. Sometimes they don't know the difference between the approved one or non-approved one, so it must be approved by the IPC department centrally in the Ministry of Health or in the 27 governorates before distributed to the healthcare workers. Thank you very much for this time, and I'll be glad to receive any questions. Thank you.
Thank you very much, Dr. Ihaf, for the good presentation, and very interesting to see that most of the transmission happens as social exposure within the hospital. I think this is very interesting, and I'm sure they will raise a lot of questions in the Q&A. Let me take this opportunity to encourage all the participants to ask questions. You can start asking the questions. Just go to the box Q&A at the bottom of the screen, and you can ask your questions there, and then we will go through the Q&A session later. Okay, so now we move to the second speaker, which is Dr. Somkiat from Thailand. So over to you, Doctor.
Thank you, Dr. Thomas. Good day to all. First of all, I want to thank the organizer for inviting me to share this experience. I will speak in 2 sessions. The first one is talking about the situation in our country, and the next one we would like to talk about our control and preventive measure. Next slide, please. At the beginning of this month, the total number of cases in Thailand are 3,425. Each day there are only reported cases less than 10. And fortunately, we have no cases for more than 100 days. But the day after I sent you the PowerPoint, they got only 1 report case. And there were only 58 cases dead from COVID-19. Regarding the infection in healthcare worker, there are totally number of 118 cases, accounting for 3.4% of the whole cases. There are more female who got infection than male. Right now, there are no number of cases die from the COVID among the healthcare workers. 17% there are no symptoms at all when we prove they get infection. Most of cases are nurses, followed by physician and nursing assistant. We also found some health workers such as driver or cleaner who get infection, but very few number. Most of cases work in the intensive care unit, followed by work in inpatient department, especially the wards to take care COVID-19 patient, and some work in OPD, ER, and the others. We try to investigate whether the cause of infection. Most of them get infection because they have to care the COVID-19 patients, followed by contact from the other staff who work together in the hospital. Some reported get the infection from the screening of suspected patient. Interestingly, 16% of the healthcare workers get infection from the community contact or non-work related. During the outbreaks of COVID-19 in our country, not only the disease, but this can cause mental health problem or the whole population. The Department of Mental Health conducted the survey to see whether the severity or magnitude of problem of the mental disorder among the several population, including healthcare workers. They did the survey during the outbreak, the peak of outbreak until the mid of July. And the data show that the 3.5% of healthcare workers get criteria for the severe stress because they use the standard questionnaire to assess the mental disorder. Nearly 10% got the depression and severe depression, and 5% reported having burnout. When compared to the general population, the percentage of healthcare workers higher, but still less than the COVID-19 patients themselves. Now, I would like to talk about our control measure. In Thailand, all the hospital, nearly all or most hospital, especially for the general hospital and the community hospital, got the IC unit and optional medicine section. Both teams have the duty to take care of the patient and also optional and health and safety for the healthcare worker in their own hospital. During the peak of the outbreak, the optional and mental disease center conducted the survey whether all the hospital preparedness and respond to the COVID infection properly. We sent the questionnaire to 109 hospitals that got a response from 67. And from this data, they show that almost the hospital that got the plan and the policy and committee to deal with the infection among their own staff. They have the incident action plan, and most of them allocate the human resource management that allocate all the staff to prepare to take care of the patient from COVID infection, and also planning for the logistics, including personal protective equipment. Nearly all hospitals also set up the health screening and disease surveillance. This means that if the healthcare worker got some illness, Lyme symptom, they have to get the health screening whether they got infection or not. And if someone proves that they got infection, they have to report to the center of the hospital and report that to the Department of Disease Control. And they got the team in the hospital to perform case investigation whether they got the disease from where and try to make a control. And we also set up the quarantine site for the healthcare worker. During the peak of the outbreak, many healthcare workers have to stay at the hospital, and someone who get infection or contact with the suspected case, they have to stay at the quarantine site for 14 days. After that, they can go out and to work as a normal. Every hospital got the regimen for treatment for the COVID-19. The Minister of Public Health set up the policy to take care of the hospital staff. They can say that both government hospital and the private hospital, if anyone got infection, they will give the free treatment. This includes the whole population of Thai people. If anyone get an infection, we get the free treatment. And we also set up the system for quarantine for 14 days, or they have to stay when they get infection. After that, before 1 month, they have to have assessment for health, that whether they can come back to work or not. And we also arrange the mental health support. Regarding compensation, actually in Thailand, if the healthcare worker got infection from the patient, they can got the compensation from the government budget. But at this time, the Minister of Public Health tried to encourage and give the moral support for all the healthcare worker. They buy the private insurance. If any healthcare worker get infection and die from the disease, they can get at least 1 million baht. And fortunately, no one get that compensation because no one die from the disease right now. Our hospital also arrange the training course and set up the guideline and manual for their own staff. They also arrange the training for personal protective equipment use and try to communicate with all their own staff what's going on and what to do and what to prepare themselves during the outbreak of the infections. Many hospitals also arrange for environmental management. For example, they have to arrange the area for social distancing, and they have to set up the restrict entry to the hospital. For example, just only one way to enter to the hospital. And then they have to prepare for the infection control room, for example, like the negative room, and install all the ventilation and cleaning and waste management as well. Next slide, please. This shows you the photo or the figure of some hospital that they try to prepare during the outbreak. And you can see one picture, they set up the entry point to the hospital with the screening. Both healthcare staff or the patient or relative, when they want to enter to the hospital, they have to get the screening by check up the fever. And then they have to got the alcohol gel to clean their hand, and they have to give some symptom, the record or the symptom before enter to the hospital. And this photo show that many hospitals try to help themselves by set up the ventilation design and equipment. Sometimes they can use only modify some plastic bag to set up the partition in the ambulance cars and install all the extract food to protect themselves, such as in the dental clinic. And you can see there's also arranged the area for social distancing by putting up the bar to keep the distance between the staff and the patient. And they can also arrange the PPE according to the risk of the staff. For example, if the staff have to take care of the patient directly, they can get to wear the whole PPE, such as the N95 and ground and all the glove, everything. But for the workers, if they have to work in hospital but not related or work directly to the patient, they can use surgical mask or the medical mask. In conclusion, healthcare worker is one of the high risk group for COVID infection in our country. And the major cause of infection is due to their duty to take care of the patient directly. You can see we have the several measures for protection and control of the disease among the healthcare worker. The measure includes health surveillance, education and risk communication, and also environmental management. The most important thing that we can control and prevent the healthcare worker are the prompt policy support and urgent intervention. And all hospitals can learn from each other. So I can say that networking and learning from each other is very important, essential measure to protect themselves from the COVID infection. Thank you very much for your attention.
Thank you very much, Dr. Somkiat, for the comprehensive presentation. I think it's very interesting to see how Thailand has managed to keep the number of new infections in the general population low, but also the number of health workers infections low and no deaths. I think this is quite remarkable for Thailand, and it would be interesting to understand it better. I mean, we have gone through some of the measures you have taken, which are very, very interesting. Also interesting to see that the main source of infection among health workers, in this case, in the case of Thailand, is patient care. So it's different for the Egypt situation. So maybe this may also raise some questions in the Q&A. Okay, so let's move now to our third speaker. And thank you very much for the first two speakers to stick to the time. I really appreciate that. So the third speaker is Dr. Kenneth Ronquillo from the Philippines. So over to you, Dr. Kenneth.
A pleasant morning, afternoon, and evening, whichever time zone you have. I will be speaking about the current status, challenges, and strategies adopted by the Philippines for our healthcare workers in the time of COVID-19. On January 30, 2020, the Philippine Department of Health confirmed the first case of COVID-19. As of current, with a population of 108.7 million Filipinos, around 2.6 million were tested, of which 10% were positive for COVID-19. This accounts for 0.22% of the population. 77.8% of the cases have already recovered, 20% are still active, while 1.6% accounts for COVID-related deaths. Since the beginning of the pandemic, the Filipino healthcare workers have tirelessly responded to the management of coronavirus in the Philippines. The current HRH stock with valid licenses for professional practice in the Philippines is around 862,000. However, only around 190,000 or 22% of the total number of professionals are in the active workforce registry. From this identified portion, 35% are practicing in private health facilities, whereas 65% are in public health facilities. In the statistics of the confirmed cases, 7,246 or 3.13% are healthcare workers, with most of the cases clustering in mild and asymptomatic categories. As of September 6, 92.8% have recovered from the disease, and case fatality ratio is at 0.6%. The emerging challenges met by the health workforce system in the Philippines can be gleaned in this diagram. The highlight concerns relevant to human resources for health. Overlaps in the issues reported reflect inadequacies in the hospital workforce, workplace safety, shortage of personal protective equipment and other materials, fatigue, mental health of and discrimination towards healthcare workers, and redundancies in some of the existing policies. The concerns are interrelated and if unresolved would lead to the aggravation of other issues and perpetuation of a vicious cycle. The slide illustrates the trend in the infection of healthcare workers by date of onset of illness since February up to the late August. After reaching peak levels of infection in March, the cases of infection among healthcare workers began to decline with the implementation of training programs on infection prevention and control and the introduction of the Sub-Task Group Health Results Framework. With the aim of protecting the frontliners and supporting the different government agencies and private institutions to continue and essential operations during this fight against COVID, issuances and guidelines to protect workers have been issued through the joint efforts of the Philippine Department of Health, the Department of Labor and Employment, as well as the Civil Service Commission. Issuances for private workplaces cover guidelines for reducing transmission of the virus, which includes the donning and doffing of PPEs, physical distancing, and instructions on frequent disinfection. These also cover the provision of disinfectants, visual prompts for safety measures, strengthening occupational and safety health programs, management of symptomatic employees, as well as contact tracing, among others. Existing administrative and department orders and memoranda from the public sector covers institutionalizing occupational safety and health in clinical and public health offices, employing alternative work arrangements to reduce possible transmission of the virus, general preventive measures, symptom management, and compensation and benefits of employees who may be infected with COVID-19. The National Action Plan against COVID-19 has provisions for protecting workers by employing the Unified Operational Framework for COVID-19 response in workplaces. It has 5 pillars, namely prevention, detection, isolation, treatment, and recovery. This framework entails linkages and collaboration among various stakeholders in the implementation of measures and programs to ensure the safety and security of healthcare workers. Infection prevention control protocols incorporate the safety standards for healthcare workers and are closely monitored for its enforcement and compliance. This also allows timely provision of supplies and other commodities like PPEs, disinfectants, as well as administrative and engineering safeguards wherever and whenever possible. To note, no PPE, no duty policies being implemented in health facilities. To guarantee representation of healthcare workers in the formulation of policies and solutions, the DOH regularly convenes professional, medical, and health-allied organizations, epidemiologists, health economists, social scientists, and other interest groups to identify HRH-related issues and gather suggestions on how these could be addressed. The testing and monitoring of healthcare workers' health status is being implemented under the DETECT pillar. Based on exposure, travel history, and/or symptoms, healthcare workers are monitored and classified accordingly as suspect, probable, and confirmed COVID-19. Isolation and quarantine assistance are offered to healthcare workers. This may be in the form of meals and accommodation, transport assistance, and referrals to proper health facilities as deemed necessary. All DOH units, hospitals, and attached agencies are also instructed to create programs that will provide mental health and psychosocial support for frontline health workers through caring for carers activities. The DOH also conducts preparedness and response assessment to hospitals as a measure to ensure the occupational safety of the healthcare workers. It is noteworthy to highlight that hospital COVID-19 top management teams or incident command centers are organized to set the overall direction and response and conduct periodic assessments of their compliance to infection prevention and control protocols and sharing of exemplary practices. Hospitals allocate beds for their healthcare workers who acquired COVID-19 in the workplace and or referred or transferred to temporary treatment and monitoring facilities or TTMFs until their recovery. While area zoning has been put in place to maintain infection prevention and control measures in hospitals and other health facilities, COVID-19 information handbook and other education and communication materials has been circulated as a handy companion to the healthcare worker to serve as a daily reminder and tickler. The WHO interim guidelines on the exposure risk assessment and management in the context of COVID-19 virus is also being used in the hospitals and the quarantine facilities. Code teams or COVID-19 coordinated operations to defeat epidemics teams have been organized in a multidisciplinary fashion to provide resuscitative assistance in the local government unit's response and health event management approach. Highlighted in one of the code team visits is the remarkable finding on human resource fatigue due to prolonged duty hours and inadequate workforce. This calls for the HRH augmentation and support from the Department of Health. It also looks into a deeper understanding on the increasing issue on workplace coordination. Hence, source of transmission and interaction dynamics have been looked into during the visits and dialogues, taking into account health workers affected in the workplace and the appropriate actions to keep them safe. In terms of insurance coverage and additional benefits and compensation for healthcare workers, the Philippine Health Insurance Corporation guaranteed full financial risk protection or full hospitalization coverage for all Filipino health workers in public and private healthcare facilities who contracted COVID-19 for the whole duration of the pandemic. Relative thereto, the Office of the President also issued the Republic Act, a law with accompanying implementing rules by the concerned government entities entitling healthcare workers assigned in enhanced community quarantine areas or level 3 transmission a one-time special risk allowance in addition to hazard pay allowance being received by them. For those who got infected with severe COVID-19, an additional compensation of approximately $2,000 is given once recovered. In case of death, the families of the healthcare workers receive a benefit aid approximately $20,000 US. As of September 7, 2020, the Department of Health has been processing claims and releasing checks for the COVID-19 severe cases and COVID-19 deaths. To aid the current efforts of the government in addressing the other HRH concerns that might not have been covered by the currently released issuances, legislators have moved towards the revision of the existing Republic Act in COVID-19 response. The current Republic Act has been strengthened by Congress with the following inclusions. So approximately $210 million allocated to the Department of Health for additional remuneration for health workers in the private sector to approximate salaries on government. So that is an additional $200 per month duty allowance. Hiring of additional healthcare workers as augmentation to the current COVID-19 workforce. This time, special risk allowance for public health workers directly managing COVID-19 patients. Actual hazard duty pay will be given for healthcare workers directly attending to the COVID-19 cases, in addition to the hazard pay from Magna Carta. Life insurance, accommodation, transportation, and meals for public and private healthcare workers. This time, also those who got infected with mild COVID-19 receive a compensation of approximately $300. Augmentation for operations for DOH hospitals that will ensure safety of healthcare workers, and this goes for engineering protocols. Priority COVID-19 testing at regular intervals for healthcare workers directly catering to COVID-19 patients, and approximately $60,000 budget for the procurement of personal protective equipment for healthcare workers. The good news is, and as we speak, the amendment to the Republic Act by Congress has just been signed by the President today. Thank you very much. That would be the initiatives of the Philippines.
Thank you very much, Dr. Kenneth, for the presentation. Very interesting. I found very interesting the framework on challenges made on the health workforce systems and the interaction and the linkages between the healthcare workers, the government, and also the employer. Quite interesting, and all the approach to insurance coverage for health workers. So thank you for that, and I'm sure, and I can see also many questions raised by the participants. Let's move now to the second section of the session of the webinar, which is passing the word to our commentator, which is Dr. Zainab Samad. He's professor of medicine. So he's chair of the Department of Medicine in Aga Khan University in Karachi, Pakistan. Over to you, Dr. Zainab.
Thank you very much, first of all, for this invitation to speak and comment on our esteemed colleagues' presentation from Egypt, Thailand, and the Philippines. Really impressive work that everybody has done. And what I'm going to try and do is just not only reflect on the work that other people have done, but also provide context from the Pakistani perspective. So I serve here as the chair of the Department of Medicine at Aga Khan University in Karachi, which is the largest city in Pakistan. And you know, just reflecting on what Dr. Ehad, Dr. Somkiat, and Dr. Rokeo mentioned, is that the safety of healthcare workers appears to be a very integral and worldwide problem. Everyone's struggling with it, and most different countries have either dealt with it very beautifully or are still struggling with the problem. And clearly, frameworks are required to actually tackle it effectively. So the numbers appear to actually follow the relative country surges. That's what I can tell from the three different presentations. So where the numbers were low in the community, the healthcare worker infections are low, but around 2 to 3% is the general healthcare worker infection rate. And that is just because of the nature of the work. They are at a higher risk than the general population. A recent Lancet paper put it down an unadjusted hazard ratio of 11 versus an adjusted hazard ratio of 3. So clearly ensuring healthcare worker safety ensures patient safety as well, prevents nosocomial infections, rapid contact tracing, decreases exposures, and prevents hospitals from becoming hubs of infection. So there's all the reason to actually prevent this. I've used Dr. Rokeo's sort of framework that he puts up here in that, you know, this is a complex issue because, and requires stakeholder engagement from three different large domains: the healthcare workers themselves, the government, and the employers. And so here you've got to think about the different angles where there is ensuring workplace safety, ensuring human resource management. There are enough people, there's not enough, so we don't have mental, physical burnout from long repeated exposures of staff to COVID-19. There is how do we isolate, how do we perform good surveillance, picking up of cases, and then providing the appropriate support to those staff as we move on with care. So to provide a little bit of context, I'm going to show you what Pakistan's numbers have looked like. I mean, with a country of 220 million, we were really expecting a large explosion of cases. We've had about 300,000, and you can see that the peak mainly happened around June 20th. And the blue represents the number of tests, and then the red line represents new cases, and you can see that it's come down over time. Again, the number of daily tests, and the red represents positive cases. So you can see that that's come down. Our mortality rates obviously have come down, as well as the cases have dropped. And this is our healthcare worker infections. 2% of the national case counts are actually healthcare worker infections. You can see it follows the same community trend. So whenever we had the peak, that's where we had the peak healthcare worker infections as well. You can see over here, and this was something that was also seen in Egypt, where a lot of the healthcare worker infections occurred from either shared collegial exposure or the community, and very little occurred, and not very little, but a small percentage occurred from actually contact with COVID-19 patients. And this is what we've seen actually in Pakistan over the last several months. Now, the principles of infection prevention and control in healthcare settings has been really delineated very nicely in frameworks, both by Dr. Somkiat and Dr. Kenneth Rocchio, in that there has to be use of standard precautions for all patients, appropriate gloves, masks, gowns, where needed. There has to be triage, recognition, isolation of suspected patients. So separate entries, for example, from what Dr. Somkiat and Dr. Rocchio both showed pictures of that. Appropriate PPE for droplet and contact precautions, availability of PPE. In Pakistan, we surveyed almost 70 hospitals all across the country. We found that most, over 90% actually didn't have any problems with PPE. We've been hearing about this worldwide, especially in the beginning of the pandemic, but this appears to be less of a problem. A bigger issue is actually teaching when to use PPE, how to use it, and to use it very thoroughly. Administrative controls to prevent healthcare worker infection. So separating them and creating environmental controls. And these would mean restructuring how you put patients together in a clinic area, reducing the staff so that there is social distancing. These are all the things that require a great deal of planning. And that's what both Dr. Somkiat and Dr. Kenneth Rocchio mentioned in their slides, was that we noticed in Thailand, there was actually auditing of what the hospitals were doing in terms of incident plans, planning committees. Was there a monitoring evaluation going on, HR management, logistics management? So that was something that was really evident. So where infection control was good, there was constant audit and monitoring and evaluation of these processes. And so putting the healthcare workers first really means you create a safe environment. You provide PPE based on the risk of exposure. There are policies for mask and physical distancing. And these are both stressed on by my colleagues, Dr. Somkiat and Dr. Ehab and Rocchio. Proper training and refreshing. So there was online training going on along with physical FaceTime in Egypt, the same thing in Thailand and Philippines. So there has to be a great deal of constant education and re-education and risk communication that was stressed by all three of the colleagues. Responding to employees' medical concerns, so free screening, testing, treatment of employees and eligible dependents. That's something that both Dr. Somkiat and Dr. Rocchio mentioned. And what I found really fascinating was the exceptional support provided by the Philippines government in terms of developing a framework for the healthcare workers who were exposed fell ill or even passed away from these infections, the life insurance policies, the disability, hazard pay, etc. Those are really important aspects of providing the fiscal cushion to these healthcare workers and frontline workers here. Hotlines to report and identify level of exposure. We created one at our university. We took care of almost 1,000 COVID-19 patients since the beginning of the pandemic here in Pakistan. And we had infections, and these actually followed exactly the curve of the epidemic here in Pakistan. And then really responding to social concerns, quarantine, people, we had, and I'm not sure what the experience in other places was, but here there was sometimes healthcare workers were targeted. So we had to create a whole security framework for our physicians, especially those who are taking care of COVID-19 patients, providing them accommodation. Both Dr. Samkiat and Dr. Rakio mentioned this, and an employee health line and through HR. So the clinical support, obviously, in addition to the great points mentioned earlier about, providing treatment, free screening, free testing, and insurance and disability and hazard pays, there has to be policies for leaves during quarantine, isolation, protocol for symptomatic and exposed staff, teleconsultations for those in isolations, because you obviously want to protect your other staff too, and early referral to take care of those who may be infected. So the surveillance systems actually are multi-tiered, beginning from the fact that the employee has to know that they are at risk of an infection and should be able to self-report symptoms, to daily screening of employees when they're coming to work, and an audit. And this audit was done at sort of large institutional level in both the Philippines, Egypt, and Thailand. But here I'm showing you an institutional snapshot of what we did. And then contact tracing, a very important network of how we would do contact tracing of positive employees, employee health protocols for exposure. So here I can show you, we developed actually a web application that is called Sehat Check. Sehat means health in Urdu. And only employees would have access to this. They would have to actually fill out a really simple questionnaire, screening questionnaire on COVID-19 symptoms every morning before they got in. And if they tested, if the screen's positive, it would tell the employee not to report to work, but in fact call a certain number where they would be then tested and so on. So that was a really important aspect of our response, and we did well on this. Here is an example of an audit. So we had consistent, constant audits, and that's what is required to improve compliance from a structural environmental control. You can see we audited a compliance of healthcare worker wearing face masks, patients wearing face masks, social distancing among healthcare workers. As Dr. Ahab earlier pointed out, a lot of the healthcare worker infections happened because they were all sitting together, eating, or social interactions with other colleagues. And so we needed to be paying attention. We observed similar things. And so we wanted this to be 100% compliance to PPE guidelines that were circulated by the institution. So this audit, for example, was in May. You can see a bunch of reds and yellows, and those are undesirable. We wanted 100% in everything. And you can see that the numbers of yellows and reds have gone down as time goes on. So the audits are really important, and a monitoring evaluation is really important. So in summary, the creation of a safe healthcare setting for these patients in a high hazard condition is to increase safety with adequate PPE policies in place, frequent audits to ensure compliance, improve environmental planning, train, refresh, and these are points that Dr. Somkiat and Dr. Rakio mentioned, and as well as Dr. Ihab, about constant training and retraining. And then positive reinforcement of good behaviors and non-punitive supportive policies. And I really like the policies that Philippines have instituted in terms of supporting, providing good fiscal cushions to the staff. In Thailand, there was a very clear, nice plan for how to, they evaluated mental health consequences of taking care of these patients and found very high rates of things like burnout and depression and so on. And so creating a framework of how to actually offer mental support to the healthcare workers is important as well. And then obviously the very general rules of physical distancing, hand hygiene, and masks beyond the healthcare setting, because a lot of what we found was community transmission in healthcare workers. So I would like to acknowledge the folks who really helped and led the response with me here at AKU. And I've actually been very instrumental in providing policy input in Pakistan. And they've been Unab Khan, who's the chair of family medicine, who really took it on for employee health. Faisal Mahmood, who is the section head of infectious diseases, and Aisha Almas, who is the service line chief for inpatient care in medicine. And again, I think our colleagues, Dr. Ihab, Dr. Somkiat, and Dr. Kenneth Riccio, I mentioned really important points. I see a lot of similarities amongst areas that have managed to take care of this pandemic and take care of healthcare workers appropriately. So thank you very much, and happy to answer questions along with the panelists.
Thank you very much, Dr. Zainab. So now we have finished the panelists' presentations and also the commentators. So now we move into the third part of the session, which is questions and answers. I'm very happy to see that there are a lot of questions for the three panelists and common questions. So the way we are going to proceed, I'm going to be picking up some of these questions, and then I will be asking each of the panelists, or in some cases, one question will be addressed to different panelists. What I really request the panelists is to be short in the answers and straight to the point, so that we can address and we can respond as many questions as possible. Let's try to make it as dynamic as we can. We have 20 minutes before we get into the closing remarks. So let's start. The first question I would like to raise is that we see as percentages that nurses are getting more infected than other professional categories. But for example, in Thailand, we were seeing that 42% of the health workers infected were nurses, while 19% were doctors, for example. But we know that there are 4 times bigger number of nurses than doctors in Thailand, or 3 point something. So the first question is, do really nurses get more infected than other health professionals categories? And if so, why? I open the floor for the 3 speakers, panelists, and the commentator. Maybe we can start with Dr. Ihab. Any answer on that? Over to you.
Yes, thank you. I've raised one of the reasons that nurses are their numbers are larger than physicians' number, for example. Second is that it is logic, because they take the vital signs for the patient more frequent than doctors do. The place that we have more infection is in my country is the place I said, as I said before, that social gathering together, like the places they eat together and the place they have taken rest and meet. This is more frequent with a large number of nurses than physicians. Thank you.
Thank you very much, Dr. Ihab. Any other comment from any other panelists on this question?
Yes, I would like to give some answer for this question. I agree with Dr. Ihab. The first reason is the more nurses than physicians. The second one, nurses have to take care of the patient all the time. Not only during to measure the vital sign, but sometimes they have to give the drug, give the medicine, and they have to take care whether any happen to the patient, especially at the ICU. So this is the reason.
Thank you very much. If you don't mind, let's move to another question, and then the others will have opportunity to speak. So this is a sensitive question. So we know that occupational health is critical in our countries, and monitoring health workers' infections is critical. But in many countries, it's not easy to get this data in the public. So it's not easy to know how many health workers have been infected and how many health workers have died. This is a reality in many of our countries. So what would be your suggestion in order to improve this? Let's start now by Dr. Kenneth. Over to you.
That's quite correct, but in the Philippines, we have a data app. So we call this data app the Data Collect app. This is provided for by the Department of Health, and it goes through for all local governments, and that's where information is taken place. It's submitted through our epidemiology units, surveillance units, and it goes up to the central repository of data. So that's how we collect data. For positive cases, it goes through another app we call COVID Kaya. This is also information that takes cognizance of all positive COVIDs. So it's easy for us also to get this information. The only challenge is that there are times that we have to validate data because current addresses are not as correct as we deem it should be. Thank you very much.
Thank you. Dr. Zainab, any reflection on this?
Yeah, I think you guys are all trying to get at open data, right? We're all better off with good data so we can hold all our governments and bodies that are responsible for this appropriate action accountable, right? And I can say that the last 3 years have been very interesting, and especially this pandemic, because in Pakistan, we haven't had amazing data, real time being displayed on dashboards for everybody to see, but we've had that. And the data that I was showing you actually is data is reported on a daily basis to the National Command Operations Center, is set up especially for COVID-19. So I think it's becoming better. And I think the WHO is the perfect organization to kind of develop that platform at a more global level. So we have a really big view of what's going on at different areas.
Okay. Any comment from Dr. Ihab or Dr. Songkian to this question?
Yes, I want to add up about this issue. I think there are 4 main things to get the information about infection among healthcare workers. The first thing at the policy, especially the policy from the director of the hospital. Secondly, the team. The director have to set up the team to correct on to run all the operation in the hospital to get start from the screening and reporting. And thirdly is screening test or equipment. And fourth, it's very important. Staff themselves, healthcare workers themselves, they have to get together and, they have to speak to each other, what's going on in the hospital. And they can get all information.
Very good. Thank you. Dr. Ihab, any reflection on this, or we can move to the next question? One question is related to Egypt, Dr. Ihab, is you mentioned the social exposure as the lead cause of infections among health workers, and then you put a number of measures in place in order to reduce that one. The question is, did you assess after these interventions were taken, what was the impact of the measures in terms of reducing the number of infections because of social contacts or social exposure by the health workers? Over to you.
It is an ongoing process that the analysis of the infection and the healthcare questionnaire of the risk questionnaires, but I don't think we have done this until now. It is going to be after this era of COVID. I think we are going to start analysis of the post measure taken inside this hospital in the next month.
So we move to the next questions. One question I think that is also coming is, how do you manage a stigma against health workers as a vector for COVID infections? Maybe we go now for Dr. Somkiat.
Actually, at the beginning, we got some problem about this, but after that, we have no problem. Thai people are very, very glad and support for the healthcare worker. They cheer up. Sometimes they come together in front of the hospital and sing a song for the hospital staff, and they give some food to the nurse or hospital staff. So I think right now we have no problem about this.
Dr. Zainab, in Pakistan, what is the situation, or what is your answer to this question?
So I mentioned we had real issues in the beginning, but I think a lot of people got up and, spoke against this, the journalists, the media, we have all these TV superstars that the public really likes. And those guys got up and started thanking the healthcare workers. So I think they set the narrative that this kind of behavior is not okay, and these people actually putting themselves on the line for you. So I think the media, the narrative building around it really helped. And obviously from an institutional perspective, the leadership really put their heart and soul into thanking everybody who was putting in long hours to take care of these patients.
Very good.
Dr.
Very
Thomas,
good.
please.
Yes, please.
You were asking me a question and I have lost connection again. You were asking me about the sample size. Yes. All the healthcare workers who have been infected, we are taking this questionnaire for them and asking them to, at that time of the study, it was the middle of June. And I think it was about 1,500 healthcare worker.
Thank you very much. And in Thailand, what was the sample? Because you mentioned a number of hospitals, but it was not mentioned the number of healthcare workers interviewed. Dr. Somkiat?
Yeah, actually there are two parts, for the screening. I mean, they try screening for the suspected case of the healthcare worker during the working. If they get some symptom or they curious themselves, they can go for testing during the peak of the outbreak. But after that, after we haven't got any cases, we conduct the surveillance screening for the healthcare worker. Is I think more than 10,000 totally for the whole country, and got a negative result.
Very good. Another question is, did you apply any interventions targeting the family members of health workers? Maybe we go now for Dr. Kenneth.
Yes, that's one of the things that we've been doing. Actually, we're partnering with the family physicians in the Philippines. And the family physicians provide the appropriate education with the families. Up as of this time, we're planning to do webinars also for families, so they get the appropriate information that they should know for COVID. We do teleconsulting and telemonitoring as well, and these are done by private physicians in the country.
Dr. Ihab, or anyone who wants to respond to these questions on family members, measures on family members?
I need to clarify that I'm responsible only for the infection prevention and control, but there is another department which is responsible for the management of the other sides of healthcare workers, what they need to manage.
Maybe Dr. Somkiat?
Yes,
Thailand.
In our country, all healthcare workers, they are concerned about this issue that I already mentioned before. When they work at the hospital, they try to keep themselves at the hospital. We provide the accommodation at the hospital, and they can stay at the hospital until, as long as they want. And if they want to come back home, they also provide social distancing in their home. Some medical doctors say, they have to enter to the house in the back of the house. They clean themselves and then before enter to the house. And definitely, if or the family member got any symptom, or if they're curious about themselves, they can go for a test anytime they want to do.
Thank you very much. Dr. Zainab, in Pakistan, any measure for family members?
Similar to what Dr. Somkiat mentioned, I think there was just guideline distribution with the family, so they understood what their risk was and how to reduce that risk. I would say there was a time when we really were pressed for beds. As you know, we don't have enough healthcare facilities to cater to the 220 million people. We did our utmost to make sure that if a family member of a healthcare worker taking care of these patients came in and required a bed, that we would make one for them.
One interesting question. Now this topic is very high in the agenda, and there are a lot of resources. So what measures will continue after COVID-19 is over? What are the lessons learned that we can bring forward once COVID-19 is over? Maybe we can start with Dr. Somkiat.
Yes, First of all, when we think that when there are no reported case in our country, we set up the platform for we call the after action review to get together among the healthcare worker to talk about what's going on, what the lesson learned, and what the gap during the outbreak is the first thing, and try to improve our activities. And secondly, we set up, as the Department of Disease Control, we set up, we call the working in normal and distribute to the hospital, try to working a new way to prevent themselves for getting for the second wave of infection. For example, we try to use enhance the telemedicine and try to increase, protection and working environment in the hospital, and try to improve all the care for every patient, every diseases.
Thank you. Dr. Kenneth?
Well, yes, the question is what will continue after this pandemic? Well, number one, we see hospital preparedness as very important, because early on in the experience of the Philippines, we were not really prepared for, and our hospitals were not prepared for it. We'll have to put more investments in capacity building, not just for the health workers, but capacities in hospitals and quarantine facilities. For local governments, more intensive training for disease surveillance and contact tracing. This should be a continuing activity that we see should be happening. Thank you very much.
Thank you, Dr. Ronquillo. Dr. Ihab, any reflection on this?
Yes, first, I hope that we will hear nearly that the pandemic has ended, but it is not quite sure it's going to be now. But I need to hope that the country will magnitude that the public now is aware about hygiene and hygiene. The public is aware now about social distancing, which was very and still a challenge. The hospitals and the administrators and the Ministry of Health now is aware about something huge called infection control and prevention. This is what we need to stress about it and complete this work in the coming few months.
Dr. Zainab, thank you very much, Dr. Ihab. Dr. Zainab, any reflection on this one?
Yeah, I think great question, Dr. Zapata. I think well, immediately we've got the flu coming up in the next few months. So kind of trying to tackle both the COVID-19 and flu together will be a challenge. But just, reflecting on what my colleagues just said, I think those are kind of the general principles of what we as a globe should be thinking about, really tightening our preparedness, investing in our health systems where they are weak, investing in critical care capacity, actually the human aspect of critical care capacity. One person remarked, we've got enough ventilators, we don't have enough people to know how to run them. It's like buying cars, but you don't have a driver. And then investment in the healthcare employee workforce, because you realize the importance of these individuals. And then last but not least, and you mentioned it very early on in your questions, was we need better data, a constant surveillance system that we are up to date on outbreaks, because climate change, I don't see that this is going to be the last pandemic we'll see in our lifetimes.
Thank you very much. I think 2 important points. We have 3 more minutes to finish the Q&A. I think we have managed to cover not all the questions, but quite a few of them. So I just want to give you the opportunity to kind of, in 20 seconds, send kind of your last message, your take-home message for the more than 140 participants we have online. So let's start in order of the presentation. Dr. Ihab, 20 seconds, just like your highlight or your take-home message. Over to you.
As I mentioned before, the most important thing to highlight for everyone that the hygiene is the most important issue in this pandemic and other pandemics. Infection control prevention must be considered very carefully in all hospitals. We have we need to clarify this very stressfully. Thank you.
Thank you very much. Dr. Somkiat, main message?
Okay. First of all, we hope we can get the vaccine soon to get for everybody, especially for the healthcare worker. But anyway, you know, while we're waiting for the vaccine, I think prevention is better than cure. So we have to raise awareness among the healthcare worker for protect themselves, for keep several measures such as social distancing, and try to improve their hygiene, you know, cleaning their hand and everything. And agree with each other about the health screening, reporting, and the important thing, the policy support is really important.
Very good, thank you. The policy, how to mobilize the policy support. Dr. Kenneth?
Well, yes, we see that the manner to manage COVID is not just the health sector, it's actually the whole of government, whole of society approach, and as much as possible to involve citizens' participation. That will be my final message.
Thank you very much. Dr. Zainab?
So I would say all the things that my colleagues mentioned earlier, plus I think forums such as this where people learn from each other, you know, you'd rather learn from somebody else's framework than do it yourself and have it not work. So I think this kind of cross-pollination is really, really good.
Well, thank you very much, the four of you. Thank you very much for the presentations, and thank you very much for the questions. Now I'm gonna pass over to my colleague, Dr. Gulen, the regional advisor, in EMRO, WHO EMRO. So over to you, Gulen, and thank you, everyone.
Thank you, Thomas. And I would like to thank all our panelists for their wonderful contribution to this webinar. I think the last words from all our panelists highlighted the key issues very well. And we have this big risk. It is important, and we really need to take measures to ensure the safety of health workers who are at the high risk of infection. And this requires multifaceted interventions. And unless we take these interventions, there is always a risk of further transmission of the infection and all further weakening of health systems. So we have to act on it. And I think we have to take immediate actions further if needed in our response to COVID-19, but also this has been another learning experience for all of us. And I think the lessons learned from this pandemic will help us to prepare better for the future such occasions. Hope we will not have, but we need to have prepared health workforce. We need to have prepared health systems. Before we close, I just would like to recognize all the health workers tirelessly working during this pandemic, some of them facing the infection, even some of them unfortunately lost their lives. So can we clap for them for a few seconds? Most of the participants, maybe we will not hear you, but may I ask all our panelists to turn on their mics and we can clap together? Thank you very much. Thank you. I would like to thank our panelists once more for their wonderful contribution, very insightful thoughts, very informative presentations and comments. I would like to extend our thanks to AAAH Secretariat for organizing this and coordinating this session. And also I would like to announce that next week on the 18th of September, on September Friday, we will have our next webinar again, which is focusing on the occupational health and safety of health workforce, but this time we will be focusing on the psychosocial and mental health impact of COVID on health workers. Looking forward to seeing you all next week. Thank you very much. Bye.
Thank you very much.
Thank you.
Bye.